record on the computer now. If anybody wants to record this via QuickTime Player or record their screen, you're absolutely more than welcome to. Zoom always asks, you have to ask permission or ask host permission. I think, allow, yeah, I think everything, you take that one off. So now everybody should be getting to the meeting, but if you want to record this yourself, everyone, we're more than welcome to do that. Right, so let's get back to it. Screen share. Okay, so yeah, the reason why I've done it in this order, femur, humerus, and rib cage, is that I think the most significant ones, where if you get from because the attachments, the pelvis and the rib cage, the pelvis and scapula, are the ones you probably come across the most. And for me, they just made sense from a landmark perspective. But one thing that we're going to be exploring today is a bit into biomechanics, because there's some interesting concepts which makes anatomy so much more easier. In my opinion, it's more about the actual mechanics rather than the muscles. And once you get your head around that, it just, again, it just makes things a lot simpler. So, at the top there. Oops. Someone trying to chat, and it will come up. Right, so week 1 recap. Learn the language, you learn the anatomy. Translations and affixes explain exactly what the landmark is. What I've got here is just a little model. We're saying the accelerated learning model. Different things that you'll see: brainstorming, role play, mind mapping, games, discussions, demonstrating, and this is going to help your learning. Now, a lot of people will have done that thing where you get a book, you get an anatomy book out, you get a pen, you get a pad, you write things down ad nauseum. You might even be, artistic and be able to do some really cool diagrams. That's brilliant, but does it stick? And what I find is that if you use different modes, such as games and quizzes, if you look at mind mapping, if you look at the role play, sounds a little bit dodgy, but role play itself and just thinking how things work. And the thing that's helped my anatomy so much is explaining it to people. So, whether it's balloons, whether it's, getting models and explaining this is why this happens, this goes from here to here. So the main message with it is to make anatomy stick, you got to use it in context. So it's not just about a book and a pen and a paper. It's about using it in different things and getting used to the terminology. I'm not a massive fan of trying to be over complex on, Instagram or Facebook. That always depends on your audience. If you're speaking to general population people, bony landmarks and, the long Latin names for the muscles are probably going to go over the head. However, if you're talking in the gym, if you're talking to your friends, if you're talking to your colleagues, and you can get to using these terms as much as possible, they do tend to stick. So remember what I was saying about creativity, recollection tools. The more you recruit, the more senses, the more you can think about, like a scene or a smell or a sound or a song. Anything that you can recruit in your brain, it doesn't matter how stupid it is, it will always stick. There's one person who I know who is on this. If I said to him, where does the gastrocnemius insert? I'm pretty sure he should be able to tell me straight away because of the analogy that we thought. And it's one of them. You've just got to create scenarios to make things stick. Because again, there's not a great deal of point in attending loads of stuff like this if in 2-4 weeks time I say, where is the insertion or origin to this? And you have no idea. So it's making things stick. So what did you remember? So this is the suffixes or prefixes, which I had to Google and make sure I got right, which is an affix. So something that goes in front of or behind a word to make a word. What do you remember? So I'm just going to stop there. People have got pads, papers. You should have everything in front of you. We've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Off you go. I'm going to give you just 2 minutes. So 2 minutes where you can get all those written down. I really would like people to have a good bash at this. So let me see if we can get this chat working. Where's my mouse gone? Right. Sorry, Tarek. I'm just seeing this now. With that one, Tarek. Oops. Oh, no. Go back. I'm blaming that one on you, Tarek. So keep going with those. Right. An epic fail there. And Aaron was saying about I should record. So yeah, so those back up. I'm recording this now, so don't worry if you don't have permission to record. Okay. So 1 minute down. So you've either done one or two things. You would have laughed at that or just rolled your eyes and gone, oh Christ, is that what he's doing? So, right, we've got another chat. Unless that's Aaron, let's see. Okay, I can't quite see that one. So. Okay guys, so let's move it along. What did you get? Going on to next one. Fossa, cave or a trench or a ditch, depending on what Latin terminology you come up with. Supra above, infra below, sub underneath, spinatus of the spine, subscapularis of the scapula, inferior lower down, superior higher up, greater bigger, lesser smaller. Ramus is a branch, tubercle is a notch, or an eminence, and tuberosity is rounded. It's not as a rounded kind of tube of muscle, tube of bone, which is why I like to think of tuberosity, tube of bone. So what I want to see is, you don't have to put your scores in, but kind of if you can score that now to see, you quickly go through which ones you got right, which one you got wrong. I'm hoping, if you've done my job right, that everybody got pretty much all of those right. So my opinion, if you know those are the main 13. You have a pretty good time in recollecting bony landmarks for the scapula and the pelvis. But if you know these as well as some kind of coordinates, so we know medial and lateral, superior we've got on there, medial and lateral, medial to me, so in towards me, into the center of the body, lateral is going laterally away from you. You know those, and you're pretty sweet with a lot of things. It's not that you've got it completely covered, and you still have to locate them, but at least you know the names, and the names are a really good giveaway for a lot of the of everything there. So next cue for me is just to talk about the scapula and pelvis. So I'm just going to stop the share there. It's going to go back to myself, and you should see the pelvis we've got here. We've got a nice plastic pelvis, and we've got the scapula going through there. And there's the main things that we want to remember is that we've got a sacral bone here in the middle. We've got the innominate bones here, which have a degree of movement, not a lot, but they do move. We've got an ilium, ischium, and we got a pubis. And then if you know those are the main body of the pelvis. If we know those, we can attach the ones that you've just seen. So those 13 different words, attach in front of those. So pubic ramus, inferior, superior pubic ramus. We've got the ischial tuberosity. We've got the pubic tubercle. We've got the gluteal tubercle. We've got all these different things. But if you know those, you are pretty sweet with the pelvis. If you know those again, we have the scapula here, a scapula with the acromion and some nice ligaments going through. If we know that a fossa is a ditch or a cave, we've got the subscapularis fossa, infraspinatus fossa, supraspinatus fossa, and then everything that comes with that. So it's really something that if you just know those points, again, it becomes infinitely easier. And if when we start to talk about muscles, we're going to do muscles of the arm and shoulder next week. When I say to you, subscapularis fossa. It's like, whoa, what's that? We just know it's the cave in which the subscapularis lives in. But it makes sense as well, because when we're talking about fiber orientations and what are going where, then you start to go, oh, I understand that. And the reason why I think this is so important is that you need to know anatomy, but then after anatomy, you need to know functional anatomy, because functional anatomy is what helps you problem solve when people have injuries or they can't do something right. So again, it's that problem solving type of thing. But functional anatomy can be a little bit scary at times, a little bit of a bitch. And I'm not going to lie, I still get a few things wrong. We've still got quite a lot wrong, actually, because things move and joints and muscles change jobs based on where everything moves. So if the pelvis moves a little, or the little bit, or the scapula moves a little bit, that joint or that muscle can then change its role, which can be very, very confusing. But it's why sometimes you can treat people or train people, you can have a thought process, but they're still having an issue, and it's because you need to understand what's taking over or what's not working. That takes years and years and years to do, but if you understand that concept, then you're onto a winner, in my opinion. So that's why, this isn't just about learn stuff because it sounds cool and you can rename really long Latin words. It's why it will really help you on the gym floor. So let me just check what we're going to now. Going through there, talk about scapula and pelvis. Right, let's get back to the screen share, because I want to talk about the main topics today. So the main content, which is going to be the femur and the humerus. Aaron's very kindly going to do the rib cage, but femur and humerus. So we had some terminology that we learned last week, which were all those 13 different things. Now I've said it's the tale of trochanters and condyles, because if you know trochanter, you know condyle, you've pretty got the femur and the humerus boxed off. I know it might sound overly simplified, but really, in my opinion, if you just understand which one is specific to which, because condyles are unanimous with both, but trochanter is specific to one of them. If you know that, then again, life just becomes so much easier in that sense. So trochanter, I had to look it up, did some research. Everybody's into research these days, which is a really fancy way of saying they Googled it. And when I Googled it, trokos, or the origination of the trochanter, comes from the Greek word wheel, which makes a lot of sense, because if you think about the way that femur or the femoral head can move in this set of element, it is a little bit like a wheel. It can go round in that way. Condyle, the best I could do was lateral part. Unfortunately, it didn't have any literal translation, but lateralis condyle on the outside, which again makes sense if we look at how that is as a feature. Epi as a prefix is upon or over, which is great, because that makes a lot of sense when we look at epicondyles. Tubercles you already know, which is a bony bit, and then we have then we have the head, neck, and shaft. Now, head, neck, and shaft it sounds a little bit dodgy, but I'm going to do a really, really daft explanation of how you can remember both the humerus and the femur. And honestly, even though it may really sound silly, I'm a big fan of the simplicity of it, and I think that if you can explain it a really simple way, it helps it stick. And the whole thing between the femoral head or the humeral head, the neck of that, and then the shaft, it just helps you remember these different things. And then we have some ridges. Now these ridges are really, really important, because especially with the femur, or the body of the femur and the humerus, these long bones, there's some really important muscles that go into there. But again, it makes sense of how we move and the structural anatomy. So the main things, if you want to have a little note down, is that we have trochanters and we have condyles. They're the two things that you just need to remember: trochanter and a condyle. Trokos is wheel. The trochanter's specific to the femur. So if you think, when people say, they've got great legs, or, grow a set of wheels, when you're doing squats and that whole thing, is the wheels help you move. And that's why it's going to be trochanter is specific to the lower body. Tubercle is going to be more of the greater and lesser tubercle, based on the humerus at the top. So make sure you get those down. Just the main ones are trochanter and condyles, and the prefix epi. They're important. I'm going to go to the whiteboard again, just to explain a very, very silly way of remembering it, but I do think it really helps. So let's stop the share again. Let's get back into here. Let's find paint light. Okay, so back to the whiteboard. So to remember the humerus and the femur, I want you to imagine it's actually just a really like a little person. Just imagine it's like a little person, because if we have them like this, but this person is really tall. They have a very, very long body. So this part of them here is going to be their body. And like all people, they have a neck. So they have a neck like so. And like all people, they have a head. Now, for all of you sniggering at that picture, I am sorry. I'm not an artist. It does look terrible, but whatever. And it looks a little bit rude. But as you can see, we have a head here and we have a neck here. Now, a little bonus tip, and I'm sure a lot of you know, this is the orientation of the femoral head, or the neck, the orientation of the neck on the femur can vary on the individual. So obviously it's not quite like a human being where we have a head at the top and then a neck there, which is directly on top. It is more so in the humerus, but in the femur, in the lower body, we can have people who have an orientation like this, so a really open angle like that. And then we can have someone who is more closed like that. And this is coxa vera and coxa vara. So if you remember, so it's a vera and coxa valga. And that's really may sound a little bit kind of Latin-y or a little bit too technical, but always remember, if you remember from last week about the pelvis, and that those three collective, the ischium pubis and the ilium, those collective three, the term is coxa. So if you know coxa, you've got coxa vera, coxa valga. That is really important. I may have got those two wrong way around, but either way, it's just an important consideration. It's never something you're going to necessarily measure. You have to be pretty good at what you do to see it in somebody. However, you can, with skill and lots of experience, probably be able to give an inclination, not an absolute idea, but an inclination of what a person has if you're doing like a hip scour test or any type of passive hip flexion exam. But, you know, from genetic variance, it is really important to know that the angle of the femoral head can change, and it can be closed and more open. So we've got coxa vera, coxa valga. And the significance of that, which I think is really cool, is the fact that you change the moment arm and the mechanical advantage of the medial glutes. So somebody with a more closed angle, which I believe is vera, so I did get that right, that wrong, but somebody with a more closed angle is going to have a stronger ability to abduct. So they're probably going to have a lot better knee stability. So I would guess, you know, people with short center masses, if you're a football fan, somebody like Roberto Carlos, Sergio Aguero, you know, just think about those short, stocky people who are very, very good at squatting. In my opinion, they're probably going to be more inclined to this, which gives them crazy amounts of stability. If you think of somebody with really long femurs who really struggles to get down into a squat without rounding the lumbar spine, my guess is that they'd be more this open angle coxa valga. And again, I'm not 100%, I might got those mixed up, but I'm sure Aaron will be able to clarify that in a sec. So we've got this little person here. They've got a head, they've got a neck, they've got a really, really long body, and they've got these little tiny feet here. So they've got these little tiny feet, and they've got these little tiny arms like that. So unfortunately, they're not the most like aesthetically pleasing, but we know they've got a body, they've got a head, they've got a neck, and they've got these tiny little arms. Now, these arms here, the upper body arms, or the upper part of the arms, are going to be the T's, the trochanter for the femur, and in the humerus, it's going to be the tubercles, and tubercles is more is that notch. Tubercles, probably spent that wrong. Sorry for the terrible writing. So the upper body here, we have the trochanter, and then at the bottom we have these we have condyles first of all, and the condyles around about here, but there's this like bony eminence, or this bony notch here, which is called the epicondyle, just above the condyle. So what I'm going to draw here, the danger of drawing a set of balls, which I know you're all dying for me to do, but unfortunately it does look something like this, which is the trochlea, which is basically the joint in which, I can't believe I've drawn this, but it's the if you're gonna put someone on Instagram, please don't put this bit up, which because it just looks horrendous. But this bit here is the trochlea, which is this is the hinge joint. So this is the knee or elbow, like so. And above that, we have a condyle and an epicondyle. And these are really, really important because they're very significant landmarks when it comes to different muscles. And when we do muscles next week, I'll be able to say, oh, and this goes into there, that goes into there. Now, the one thing is, though, here is that I've drawn this this is a merge between a humerus and a femur. Because what I've done here is I've given it a head or a neck, which is more to do with the femur. But what you'd find is in a femur is that the greater trochanter is round about here, and then it's like a cross section here, and we have the lesser trochanter there, which is this notch, which is slightly posterior, it's slightly behind. And so it would go across like so, and we've got this angle, which we know is either coxavera, coxavalga, or is the inclination of the neck, and then we get the acetabellum, which goes around like that, which is a bit of a better draw. I'm actually quite proud of that one. So we have the greater trochanter, and this is kind of connected, if you will, or whatever you want to call it. There's a line here, which is the intertrochanteric line, which goes there like so. Now, this little lip here, this greater trochanter, I think is a very, very significant bony landmark. And you could argue that they all are significant because, everything's important, in which it is. But I think that knowing that there's so much that goes on in this area, in my opinion, that it just helps with a lot of understanding biomechanics and mechanics in that standpoint. So with this one, there's like this little hollow ditch, and I do have a femur next to me. It's a plastic femur, you'll be happy to know. But it's there's something called the intertrochanteric fossa, or the greater trochanteric fossa, which again, as you know, is a cave or a little ditch. And in a lot of anatomy textbooks, you'll see a lot of greater trochanter insertion points. Now, the reason why it's unanimous is with loads of different things is because there are a load of different muscles that originate or insert, let's say insert sounds better, insert around here. However, I greatly disagree that they'll all be in the same spot. They'll all vary in different parts of the trochanter and be in different parts of the fossa in that little cave. So it'll be spread out slightly by the tendons. Because if you just think about all the different things in the different directions, from not just the external rotators of the hip, and also the medial glutes, which are at the side here, and all the other things, I do think we couldn't just have one attachment site for us to have the freedom and movement and control. They would need to be spread out slightly, very, very slightly around this area. Now, the significance of the lesser trochanter here is that if we follow it upwards and go in that line, that's the directions, the psoas and the iliacus, so the hip flexors, which again has significance when we come to doing anatomy next week. Now, when we look at the humerus, or if I was just to take this down and we're going into a humerus, it's pretty much the same story, but just not as dramatic. So again, I'm going to have to draw a penis bone, so it's not going to look that great. But if we've got a humerus now, there's not as much of a dramatic exaggerations of the head and neck as there is in the femur. So we've got this now a tubercle. It's not quite a trochanter, it's just more of like an eminence, which are like a bony bit, which is the tubercle, and we have a greater one and a lesser one, but it still has this cross-sectional relationships where it's going like a diagonal, like so. We're going to, at the bottom, still have some epicondyles here and here, and as you'll know from last week, epicondyles, if this is the anatomical right arm, so if we're looking at this person from an anterior perspective and this is the right arm, this would be the medial epicondyle and the lateral epicondyle. So medial to me, so this is me, so I'm going in that way, lateral on the outside, so that's going that way. Why is this significant? Because if you understand the epicondyles and which ones insert where, again, I don't like to generalize. I don't want to say it's as simple as this. When we start to look at the forearms and the lower limb, so the kind of foot complex and up, so when we go from the below the elbow and below the knee down, I do think these have this significance, because generally speaking, I don't but just to give you an idea, medial, any of the flexors, so forearm flexors, are going to attach to the medial epicondyle. Anything that is an extensor of the forearm is going to be in the on the lateral side, and that helps me tremendously when I've got people with forearm or shoulder pain, especially forearm pain, because then I know what to chase. And it also, if you know, the jury's out, people, you know, myofascial slings and myofascial connections. If you just look at what attaches to what, that is your myofascial sling in itself, because if something moves, another thing moves. And if we look at the lateral part, which is going to be like the ulna, when we split this up into two, so this is going to be two bones here. We split that up into two. The lateral part, the ulnar part of the lower forearm, just become relevant there. So when we look into the lower limbs, from the elbow down and the knee down, these are of significance. We have a medial and lateral, and we know that we have a condyle, which is the little bony eminence. If we have an eminence, we have an epi, it's just above. So just to reiterate and go through, the femurs and humerus, we have it's a little person, they have a head, spelled H-E-D. That's fantastic. Well done, Chris. So a head there. They have a neck. They have little arms at the top, which is the trochanter or the tubercles. They have a long body. And they have feet at the bottom, which is the epicondyles here. So it's this little person that looks like that. Now, to really risk the taking this sexual endos even further, the body of the bones are usually called shafts, so they can sometimes be called shafts. And they the significance with this is because some muscles will have really, really strong attachments to the body or the shaft of the humerus and the femur. One of the ones which I think is significant is that if we go over this way, or the significant ones to know, is that the short head. So if we go short head of the bicep femoris, that the attachment, so the hamstring, the attachment is on the is the origin attachment, which one good is going to be on the shaft of the lower part of the femur posteriorly. And then when we look at the posterior aspect of the humerus, we also we have the triceps and the medial head. Let me get that right. Yeah, medial head is going to be the lower portions as well. So it's like we have like repeat mechanics, shall we say. So if we're looking at the humerus in the mechanics from a biomechanical standpoint, which I explained at the beginning, is something we're really going to look into today, is that we have what I would say is repeat mechanics, where there's similar things going on in the upper body and the similar things going on in the lower body. And if we were to look at this from a mechanical system, so if we were to say, right, there is an axis here, and this axis, so this is a ball and socket. So we're not talking about anatomy now, we're talking about just mechanics, not biomechanics, we're talking about mechanics. And we need to give this arm, or we need to give something with an attachment, freedom and movement. So we have this ball and socket joint here. Now we're going to have an attachment, or we're going to have something that comes out in this sense here, and then that's going to have a hinge which attaches to here, like so. I'm sorry about this terrible drawing, but this is like a mechanical system now, where this is a hub which is attached to a larger base. And what it needs to do is it needs to be able to orientate this upper arm in different regions. So if we said this was a crane or something like that, if you think of like a digger and it's moving something and it's trying to scoop something out. So we'll use the digger analogy because that makes sense. And it needs to move it around. So we have a pivot point, a longer arm, and then a shorter arm like that. And then something which attaches or makes contact with something. So this is the ground, this is a hand, you know, this is something. So if you think about that digger that's scooping up mud or whatever you want to think about. Now, the reason why this is significant is because if you look at it from this perspective, the mechanics of the scapula and the pelvis are very, very similar. And especially if you look about how the humerus moves in the attachment as well as the femur moves in the attachment. But we got what I would say are anatomical clues. And if you think about it, and if you're really, really clever, I personally believe that taking the trunk away, we're just a mirror image of the biomechanics from the upper body and lower body perspective. And that, again, in my opinion, makes anatomy so much easier, because then you just think, right, what is my lower body this? What is my lower body that? because I think that one of the biggest clues is that we, if you said biceps, you think arms, but we have a bicep femoris, which is a hamstring, and we have a bicep brachii, which is in the arms. But they're still doing the same job, which is causing flexion of the joint. They're just the opposite way around. So if you flex your bicep in your arm, your hand will go in front of you in the sagittal plane, it'll go anteriorly. If you flex your knee, or if you flex your bicep femoris, your arm will go backwards. So it's that mirror image relationship. And the significant ones for me are the thing that we have a tuberosity, and we have a tuberosity for both our deltoids, which, believe it or not, is called the deltoid tuberosity, and we also have a tuberosity for our glutes. So we have a gluteal tuberosity, which is posterior, just underneath. So if I go back up to this very, very dodgy looking femur, it's round about here. If you look at the deltoid tuberosity, it's more lateral, and it's going to be about on the outside here. So we're going down. So we've got tuberosity for the deltoid and gluteal. So that's really interesting, again, from my opinion, because then we're saying, well, things are really starting to repeat there. And then if you look into where things attach and what they do, we start to see that the deep hip rotators are also the same as your rotator cuff. We have 4 muscles that govern the movement and the external internal rotation in the shoulder. And we have we have a lot more in the hip, but we have 6 muscles and maybe a few more if you're looking at the iliacus and the psoas major. If we're looking at those, they're going to govern the rotation and internal external rotation of the hip. So it's the same thing, and I really love this because it makes things easy, and it makes things easier to recall, but it also means when you're looking at things from a movement perspective, or you're looking at things from a treatment perspective, you have a better idea of the interrelationship between the two things. So, and what I mean by that is that I don't want to go into that because it's a whole different rabbit hole. But when we look at walking mechanics and why there's a relationship between the contralateral sides between the shoulder and the hip, but that's a whole different story. So I'm just going to stop the screen share there. Because I want to just get the femur out. I wasn't able to get a humerus, but this is just, obviously I've drawn the pictures there. But just to reiterate, we have, let me get that right way back. So this is a femur which I got from work off my skeleton, and just that little person thing, that little person with there's his head. So this is the head of the femur, which is going to go in the acetabellum. We have the neck here, so the neck of the femur. We have the greater trochanter, which is going here. And if you look round, if I show it from the anterior view, you can see that we have this greater trochanter up here, but this intertrochanteric fossa, which is again, I don't know how advanced the anatomy books that you have are, but the ones that I've got, there's plenty of ones that I've got which all say greater trochanter. Again, in my opinion, if you went really nitty gritty into the anatomy, you'd probably have to differentiate by where they insert along this top line here. We have, as we go down, we have an intertrochanteric line, and then we have the lesser trochanter here, like so. And if this is the knee joint, so we've got a patella, so you should be able to see the patella. If I go down like this and then just rotate round, you can see how that lesser trochanter is slightly posterior. So it's not medial, it's not at the front, it's slightly posterior, so it's at the back of the body. Now, something that I didn't write on, which is really, really important, it's massively important, and there's such a cool muscle which tells you so much about running, walking, hip hinging and squatting, is something, if I spin it round here, which you probably won't be able to see, and there's this line here called the linea aspera, which I'd like you to write down, massive, like linea aspera here, because that's going to be the origin of the insertion point of the adductors, which again is such an important muscle, which I went on a lot about last week. So that linea aspera, I don't know, I haven't looked up what aspera is, but linea, just think line, but aspera in Latin, but line, just this line here is very, very significant, sorry. So as we go round and spin around through, you'll see this guy's little feet. So here again, we have a patella, if we're looking at it from this side, if we go up, we can see the head of the femur. And if I draw this down like so, we'll be able to see this is the medial epicondyle. We have the supracondylar ridge around here, which, if from an attachment perspective, there's not many that I think go into here, but from an attachment perspective, I'd be more concerned about knowing the medial and the lateral epicondyles. That's a very important one. This section here as well, we have the adductor tubercle. So again, we talked loads and loads about the adductors. A big fan of the adductors, but we have the adductor tubercle, which is around this region on the medial epicondyle. And that forms something which is called the pes anserinus, which again, are we talking for the sake of talking fancy terms? I would say that's significant because we have rough line. Cheers, Tash. Nice one. Linear aspera, so a rough line that goes through there. Nice one. So we have the adductor tubercle, which is known as the pes anserinus, which is the insertion point for the adductors, gracilis and sartorius. And I used to really overlook those muscles and be like, yeah, whatever, you know, they're just, no, I'm not really bothered about that. You're never going to train sartorius day, but they are really significant for when it comes to functional anatomy. And the reason why I get annoyed with those muscles is because they have very, very confusing roles. One can internally rotate the thigh, but they also externally rotate the tibia, which really pissed me off because like, how the fuck does that work? But it is really cool. So that's important to know because those muscles, I know the gracilis that comes here, goose foot. Yeah, nice one out. So yeah, so your goose foot here, and it's because it looks a little bit like a goose foot, I think is because there's those attachment of 3 there. So so we've got the adductor tubercle, which is basically just around or in the same region as the medial epicondyle. We've got a lateral epicondyle. We've got the body of the femur, linear aspera on the back. We've got on the back as well, so posterior, we've got the gluteal tuberosity, which is the back here. If you think about it, if we're looking at hip extension, that makes a lot of sense. We've got this lesser trochanter, intratrochanteric line, which takes us from the lesser to the greater up here, which has a little fossa, which we know is a cave, which is where all these little external rotators are going to live. And then it goes from the neck, which can have a different inclination, and the head here. When I say inclination, it can have like a greater angle or a smaller angle, which Vera Coxa, Coxa Vera is shorter, Aaron, I can see you. Is it? No, yeah. And then, nice one. Yeah, so I did get it right. I think I wrote it wrong, but I did get it right. So valga is when it goes at higher angle, and Vera is when it goes at lower angle. Just an important consideration. And, you know, if you're ever on the gym floor and somebody, you know, you happen to nip that in, your client might go, wow, they're very clued up. And brownie points is we have anteversion and we have retroversion, which I've not, can you see? So, right, how am I going to describe this correctly? Because it just looks like see there. But when if I'm looking at this perspective, and I think it'd be better if I go like this, if I bring the head of the femur and I rotate it, if I externally rotate it, so turn it forward, we have anteversion. And then if I rotated it backwards, we have retroversion, which is anterior and posterior pelvic tilt, because the pelvic has to do a reciprocal effect and change its position. So anteversion, retroversion. That one is like, if you remember that, it's a big bonus. It's a very, very good thing to remember. But that's massive. That's a really, really big one in my opinion, because that just basically is as the pelvis goes into pelvic tilt, anterior tilt, we have anteversion. As it goes into posterior tilt, we have retroversion, which is a big one for knowing hip mechanics and where things are placed. And the reason for that is it impacts your ability to externally and internally rotate. So let me unmute. Aaron, are you Aaron Caseley or are you Mofo? Which one are you? Mofo, I think. Let me see. Mofo. Yeah, Arnie's unmuted. Cool. Right, Aaron, I'm going to make you the host. Where are you? Oh, you'll be at the top, won't you? Cool. So, make host. You are now the host.
Perfect. Right, guys. How you doing? Thank you very much indeed for inviting me on, Chris. For those of you who don't know me, I'm one of the directors of a Mofo Body Mechanic, which is a sports osteopathy clinic based in Leeds. For my other job, I do some lecturing at Leeds Beckett University, of which anatomy is one of the subjects that I teach. So we're going to talk a little bit about the thorax and the ribs specifically, and I think it's important that you understand the significance of the areas that you're studying anatomically to give it some context. So the thorax, we all know, protects the vital organs, the heart, the lungs. So it's a complex interplay of stability, and you also require a degree of mobility through there. Things like, from a PT perspective, you know, if your thorax is stiff, your thoracic spine is stiff, you tend to find that that impacts on shoulder mechanics, shoulder movements, elbows, wrists. So from a functional perspective, this complex interplay between stability, which is required to protect the vital organs, and mobility is a really important concept. Now, in terms of your ribs, we have atypical and typical ribs. The atypical ribs are described as atypical because they're not the same shape. They're slightly different. And the atypical ribs, I can highlight on here. The first rib, that's an atypical rib, because if you look at the shape of that in comparison to ribs 3, 4, it's a different shape. The second rib, that's described as atypical. And then we come all the way down to the bottom here, and we get to the 10th rib, which is there. That's another atypical rib. And then the 11th and 12th. So they're described as atypical because they're a different shape. Now the typical ribs, we come up to the third rib, that's the second one, and that is your third rib. I'm going to expand that. Now, just like Chris was talking about in terms of heads, necks, this end of your, let me get some pens going. So here, this is your rib head. Underneath the rib head, we have the neck. And as you can see here, we have a little tubercle. Now, this end of the bone is what articulates directly with the thoracic vertebra. So the head, this bit here, articulates directly with the vertebral body, and that creates something called the costovertebral joints. And this part here directly articulates with the transverse process, the bit that sticks out the side of the vertebra. And that's described as a costotransverse joint. This end is vicariously described as the anterior end. It doesn't really have a name. And in most situations, if I just scroll back off this, the anterior end articulates with what we call costal cartilages. And these are basically connections with the sternum. Now, when we describe ribs in terms of true ribs and false ribs, what we're talking about there is whether they directly articulate with the sternum or whether they articulate via another rib's costal cartilage. So the sternum is composed of 3 different parts. Top part we've got here, which is the manubrium. This part here, which is the body. And I don't think this comes up very well. This is the xiphisternum, this little bit at the bottom here. This is the reason why when you're doing CPR on people, you try and make sure you place your hands into the middle of the chest, because if you're over the xiphisternum, excuse me, you end up puncturing the xiphisternum, breaking the xiphisternum off and puncturing the heart, which means that resuscitation is almost impossible. So these are your costal cartilages. Now the true ribs, the ribs that directly articulate with the sternum, are ribs 1 to 7. So we've talked about typical ribs and atypical ribs. We're now talking about true and false ribs. So ribs 1 to 7 are described as typical because they directly articulate with the sternum. False ribs are ribs 8 through to 12 because rib 8 articulates with or connects with costal cartilage of rib 7. So it doesn't connect with the sternum directly. It comes as a byproduct of the connection between costal cartilage of 7. We then come down to these 2 ribs here. These are 11 and 12. And as you can see from the diagram, there's no anterior connection between those 2. Now, things like, from a clinical perspective, which may be relevant or not, When you wear lifting belts, one of the common injuries I see with people's positioning of the lifting belts is they tend to go underneath their 12th rib. They position the belt so it's underneath the 12th rib. When they increase intra-abdominal pressure, when they're going for their lifts, they're pulling the deadlift or they're squatting, the intra-abdominal pressure and the position of the belt forces the rib out, which then starts to cause 12th rib problems. Now, interestingly, these feel like they've got a stomach problem. I've had numerous people come to me and say I've had various, medical investigations where they've done endoscopies and colonoscopies trying to work out the cause of their abdominal pain. And a slight belt position change, so wearing the belt actually over the diaphragm, more into sort of this region here, seems to alleviate that 12th rib problem. And I think, Chris, that's that.
Yeah, fantastic. I'm really pleased with that. And what would you say regarding the acromion? Just go a little bit of the joint here.
The acromion up here?
Mm-hmm. Oh, no, sorry, the clavicle, sorry.
Clavicle, yeah. I mean, I think, your thorax it's a boney cage, essentially. And the clavicle obviously directly articulates with the manubrium. So this joint here, the sternoclavicular joint. This is a joint that connects the medial end of the clavicle with the manubrium and the sternum. Now, this is really important in terms of, we talk about the shoulder in terms of the shoulder girdle and in terms of the shoulder joints. So essentially, for your shoulder girdle to move effectively, you've got to have sufficient movement at the sternoclavicular joint, at the medial end. You've got to have sufficient movement at the acromioclavicular, the lateral end, because that's what helps to orientate the position of the scapula.
Perfect. And if you prevent take your share down, that was brilliant. Thank you very much, Aaron.
Perfect. Thanks, buddy.
And then if
we'll get rid of that. How do I get rid of that, Chris?
There we go.
There we go.
Back on board, yeah. So we're back to myself and Aaron. And then if we look at this, model here, where we've got the scapula and we've got this clavicle here, we've got the sternoclavicular joint, which is going to be here, like so. And that articulation is really, really important. And again, from a training perspective, it's not something you're going to come into, but that kind of like first rib clavicle relationship is something that we explore a lot in osteopathy and looking like scalene, sterno, and breathing mechanisms. But it's just something to consider is that, saying that if something can't move, something has to move more or less. The relationship between this junction here and general shoulder health through all the connections through this clavicle into the acromion. Acromion has a spine and then it goes into that. So yeah, no, but thank you very much, mate. Awesome.
Can I just add something? So in terms of the thoracic spine mobility stuff, I think one of the biggest things you can do from your client's perspective, because we spend an inordinate amount of time sitting down in this day and age, is if you want to try to improve shoulder health in the clients, improve your thoracic spine mobility. Because you find there is a direct relationship between the thorax, the thoracic cage, and the scapula, and then what the shoulder joint's doing on top of that.
Definitely, yeah. It's I think one of the things that is going to be a big impact is the sitting. I'll be honest, I've found it myself just from doing so much laptop work, because I do have a high amount of time on my laptop. But with that as well, we're going to go with the laptop. Sorry. I find that a lot of people, I have a very stiff neck, and I've been spent a lot of attention on before training, before we do anything, is just freeing that up. But again, if anybody obviously looks at my content and Nick's content, is you can have a big impact through breathing, but getting that shoulder moving. You've done quite a recent series on shoulder health, haven't you, Aaron, on your page?
Yeah. We tend to try and jump on body parts for a while, depending on what comes up in clinic.
Mm-hmm.
So we've done a few posts on shoulder mobility, active mobility stuff. On the feed, on the Instagram feed.
Brilliant. Cool. Let's have a little bit of fun. I've wanted to do this because I think it would be quite fun to do. We're going to get everybody up into here, and should have changed everyone to the full screen. We've got 50 people on board. Let's see. I wanted to do a screen share with the Ken Hub which is a kinesiology, where you do like a test or you do an exam, and that's been quite fun, where you can do screen share with that. But what I might do is pick on random people and see if they can. So it could be anybody. Right. Okay. Let's go for this bit here. So this is a scapula. I'm going to put into this section here. I want everybody to think, what is this here, the bony part of here. So I'm going to show you here where my finger is, right, so, right, like so. What is that? So have a think, have a think, have a think. And let's go with you. Oh, come on. Come on, let's see it. Unmute, a little mute. It won't let me unmute. That's really annoying. Right, so we've got this part here. I'm so excited about doing that. You know that bit in Ant and Dec where it's you and it comes, and then your thing comes up on the thing. Right, do you know how to unmute, Aaron?
Let me have a look. I'm not sure if I've got.
Oh, it's because I'm not the host. Ah, that's it. I'm now the host. You were the host. That's why you had me there. Right, okay. Now we're talking. Right, so we've got this bit here. We're only going to do 5. Just have a bit of fun with this. Just want to make sure that everybody's taken on board. So this little, whatever this is here, if everyone can see that in the, whatever this is, I'm not even going to tell you what this is. And let's go with Jimmy Brown. Jimmy, what was that? What is this here?
Supraspinatus fossa.
Nice. Well done, mate. Congratulations. You're not going to Disneyland, unfortunately, but you got it right, so that's what matters. So, right, let's go with. Okay, we've got a pelvis now. Here's the pelvis. I'm going to let you have a good look at everything. 1 second. Let's go with here, and if I'm going to spin it round, I'm going to go to the back now, and I want to know what this part of the back is here. So we'll show you. We've got whatever this is here. There's something round here, and I'm going to go Laura McLean. What was?
Hello. Tuberosity.
Well done. Good. We're getting somewhere. Nice. I like it. Right. Let's go. Right. Let's go with. We've got this here now. So this is a femur. We've got a femur. Like, I shouldn't have said that. But anyway, you know it's a femur anyway. And let's go with what is this point here. So we've got this, whatever that is there. And let's go with Liz Robertson. Liz, are you there? Liz? Nope. Okay, we'll go to another one. Let's go. Abby Butler. What's this?
Lesser trochanter.
Brilliant. Well done. Awesome. Right, cool. Let's see. Let me see. Right, okay. We've got this, whatever this is. And we're going to look around. Let's go here, whatever that is. Let's go with Andrea. What is this bit here?
I think I'm going to ruin this drink, mate. I have no idea. Really.
So what's this bit here? Come on. Okay, right, yeah, so no, I've completely wrong.
I've popped it now, haven't I? Sorry, folks.
It's all right. I've proper stitched you up there. Right, okay. So, no, we're going to have to offer it again. Let's go with Anthony Barnes. What is this here? Anthony? Have we got Anthony? Nope. Anthony, are you there? Are you there, Anthony? Okay, no. It's tense, this. I don't know if I like it or not. Right, let's go with Daniel Clubs. Daniel, what is this part here?
Is it the ischial spine?
Nice. There we go. That's brilliant. Nice one, mate. Awesome. Okay, let's do one more and let's go with let's do this. So actually, now I'm going to get a no, I'll keep it to this. Okay, let's go around this region. Let's talk about this region here. There's a patella here, so there's a knee, and what we're going to go around this region. So what's round this region? Let's go with Zach Gonzalez. What is round here?
Not a fucking clue, mate. Come on, man. I'm Spanish. I can't pronounce this shit. I can't do it.
Okay, that's brilliant. Right, I'll send you. Apologies for anyone with kids around, but that's brilliant, mate. Okay, no worries. So we've got medial epicondyle, the femur. We've got
epicondyle,
adductor tubercle around this region here. Brilliant. Thanks for that, Zach. That's brilliant. Okay, so let's get everybody off there. Right, I'm going to take a quick picture. But no, thank you very much for that, guys. You'll get a follow-up email. You'll get a follow-up email after this. Next week is going to be the muscles of the shoulder and the arm. Brilliant. Thanks very much. Yeah, so we've got the next week is going to be the shoulder and the arm muscles now, and you will be able to do this really, really easily because we've been through the bony landmarks. Everything will start to make sense. I can start to talk about functional anatomy, which is a lot of fun. I've recorded this, which I think will be to my downfall because I'm sure everybody will want it sent. I think I'll find a way of sending that through if you do want a recording. Just bear with me because it does take a while to get that through to everyone, but I've done a recording this. I'm going to record them for the future because I have a few people requests for that. Apart from that, thank you so much for coming along. Have a wonderful day. Stay safe. Enjoy the weather, and hopefully see you all next week. Take care, guys.